What is dyspnea? The clinical definition of dyspnea is an uncomfortable awareness of one's breathing effort. It is a normal symptom of heavy exertion, but becomes pathological if it occurs in unexpected situations.
Hi, I'm Frank Kanabi, a PA student. Can you tell me why you're in here today?
I just have a hard time breathing.
Can you explain, like, hard time breathing?
It was like yesterday morning I woke up and I had a coughing episode, and after that it was just a really sharp pain and on my left side, and then I just had a hard time breathing, and it just progressively got worse and worse. I thought I just slept on it funny or something, but it just got worse and worse.
All right, so you were coughing, you said, when you woke up?
Yeah.
Coughing. Okay. Anything make it worse or make it better?
If I lay down, it's a lot worse. I do better getting breaths in if I sit up or stand up.
Can you kind of show me where the pain is?
It's right there.
Does the pain go anywhere else on your body?
When I breathe in, it goes to my other side.
To the other side? How about any pain in the back, in your back at all?
No pain in my back.
All right. On a scale of 1 to 10, or 0 to 10, 0 being no pain, 10 being the worst pain you've ever felt, what would you rate it?
It's probably about a 7 or 8 right now. When it started out, it wasn't too bad as far as pain, but it was like a 5 or 6, but now it's like a 7 or 8.
So it's progressively getting worse.
Yeah.
Okay. And the type of pain, it's sharp, is it dull?
It's sharp.
And it's constant? Or does it get worse when you take a breath in?
It gets worse when I take a deep breath in.
Okay. And this is within the last 24 hours? You said this morning when you woke up?
Yeah, it was about yesterday, and so it was about 24 hours, a lot for 24 hours today.
All right. Mr. Smith, do you have any allergies to medications?
No allergies.
Are you taking any medications?
Just like a daily vitamin and some Tylenol every once in a while for a headache. Other than that, I don't have any.
Okay. How about some past medical history? Any operations, procedures?
I broke my leg when I was like 16, but other than that, I haven't had any major problems.
Okay. And you ate this morning?
Yes.
And is the events, you just woke up and were coughing, and that's when you felt the pain? All right. And there was no trauma? You weren't in a car accident? You didn't get punched? And nothing? All right. Any history of asthma?
No history of asthma.
How about smoking? Do you smoke?
I smoke about a pack a day.
Okay, pack a day. All right. What I'm going to have you do now, your family history. Is there any lung issues in your family?
Not that I know of.
Parents?
No.
Okay. All right, what I'll have you do is remove your shirt. I'm going to do a visual assessment on you. I'm going to listen to your lungs, see what's going on, and then also I'm going to order an x-ray, and that way we can see inside there, see exactly what's going on. I understand that you're in considerable pain, so I'm going to leave here and go consult with my PA. If the pain does get worse, let the nurse know.
Okay.
All right? Thank you, Mr. Thomas.
The causes. The main physiological factors are constriction of airways, reduced oxygen tension in the diaphragm and chest muscles, tense states of the diaphragm and chest muscles. Exacerbating causes in the pathophysiology of dyspnea are mouth breathing, chest breathing, presence of inflammation, and mucus in airways. The assessment. Dyspnea assessment using acronym OPQRSTU and D.
Hi, I'm Nathan Myers with Castle Rock Fire Rescue Department. This is my partner, Eric Bachhacker. Today we're going to walk you through the dyspnea assessment scenario. First thing you're going to want to do is make sure you have the appropriate PPE for the scenario. Today we've decided to use gloves and eye protection. When you walk into the scenario to do your initial assessment, you will manage the patient's ABCs, airway, breathing, and circulation. So you'll check for lung sounds. The proctor will tell you that the chief complaint is shortness of breath. To assist in the patient's breathing, you can add oxygen. If the oxygen is not helping the patient's condition to improve, you can assist their breathing with the bag valve mask. Moving into your focus history, obtain a history of the current event using the OPQRST mnemonic. Obtain a baseline vitals. If available, apply a pulse oximetry and capnography. Also, hook your patient up to the heart monitor, and if your local protocols allow, complete a 12-lead EKG. Obtain a sample history from your patient and begin to examine the patient for physical findings. Begin your physical assessment. Start with the head, the ears, the eyes, the nose, and the throat. Move down to your chest, check for normal dimensions, and palp for any tenderness, and look for any abnormalities. Listen for lung sounds. And check for heart tones. Move down to the abdomen and palp for tenderness and distension. Also check to see if they're belly breathing. Then move to all four extremities, checking for abnormalities and distal pulses. Consider underlying causes for the patient's condition. Begin treatment based on your findings and determine whether or not the patient needs to be transported emergently or not. Perform an ongoing assessment and reassess vitals every few minutes. This concludes the dyspnea assessment scenario.
Then the onset. You have when did it begin, and then the treatment, what medications and treatments are you currently using. The provoking and palliating. What brings it on, what makes it better, or what makes it worse. The quality. What does it feel like? The region and radiation. Where is it? Does it spread anywhere? The understanding. What do you believe is causing this symptom? Severity. What is the intensity of the symptom? Values. What is your goal for this symptom? Symptoms. It's likely to be experienced differently by different people. It's often described as an intense tightening in the chest or feeling of suffocation.
Does the time start now? Yes. All right, so in 3 minutes, I hope that I can summarize what we do and pique your interest a little bit. So in my lab specifically, I study the symptom of dyspnea. So for those of you who are not familiar with that, it's another more technical term for breathlessness or shortness of breath. And really the technical definition is that it's a subjective experience of breathing discomfort that people commonly will experience during physical activities such as exercise. So we're all familiar with this type of sensation. What's important is that this symptom is actually a common and very debilitating symptom in patients with chronic heart or lung disease, and particularly in the context of exercise. So you have individuals who have smoked for a long period of time, they develop emphysema or bronchitis, and they become extremely uncomfortable. It limits their activities of daily living and really leads to an impoverished health-related quality of life. So here I have a gentleman with COPD, and on the right side there you see reasons for stopping exercise. So we bring a large number of individuals into the laboratory, we put them on a bicycle, we ask them to exercise as long and as hard as they can, and when they're completely at their point of exhaustion, we say, why did you stop exercise? Your breathing discomfort, your leg discomfort, a combination of the two, or something else. And you can see that as many as 63% of these people complain of shortness of breath as the primary reason for them stopping exercise. So that anchors it from a clinical perspective that this is a very important symptom to understand so that we can effectively manage it and treat it. So a brief neurophysiology of this symptom. In the most basic sense, breathlessness really reflects the relationship of the drive to breathe and how well our respiratory system is able to accommodate this drive. So when healthy individuals, like presumably everybody in the room, you start exercising on a bicycle in the laboratory, we have increases in the drive to breathe and an appropriate response to the respiratory system in terms of how much volume we breathe, how quickly we breathe, and so on and so forth. And under these conditions, we get a normal awareness of an increase of our breathing. It may or may not be inherently uncomfortable, but we definitely notice our breathing. However, you take an individual who, say, has developed through bad habits, emphysema or bronchitis, and what happens is that they have a very accelerated drive to breathe. So there's a lot of drive going from the brain to the respiratory muscles, but because of the sickness of their lungs and their airways, they can't essentially do the work that's necessary to match it. And under these circumstances, people become incredibly symptomatic and incredibly short of breath, and they're limited in their exercise at levels of intensity that we take for granted walking upstairs.
The treatment. Treatment often includes medical therapies that can greatly reduce symptoms in some cases. Surgery may be used to treat underlying causes of dyspnea.
Welcome to this series of short videos to help you manage shortness of breath. When you're short of breath, it can be very scary. You can feel helpless, out of control, and it impacts your quality of life. Our hope is that this series of short videos will help you to manage this symptom and to improve your breathing. Remember, it's important to talk to your healthcare team about your breathing. There are many things that can be done to help it. They're there for you and they want to help. We hope you'll find some information that will help you. We're going to start out by learning abdominal breathing. This is sometimes referred to as diaphragmatic breathing, breathing from the lower chest, or breathing from the belly. This type of breathing is important because it helps us to get enough air into the deepest part of our lungs to take the deepest breath possible. To learn how to do this correctly, we first need to find our diaphragm. And I'd like you to join me in taking your hand and placing it on your belly, below your ribs, but above your belly button. Now, give a cough. The muscle that you feel coming up and pushing against your hand is your diaphragm. Now that you've been able to locate where your diaphragm is, I'd like you to take a breath in. And when you take this breath in, it should push your hand out, and you should see your hand and your belly rise out. Let's do that together. Good. Let's try it one more time. Okay, now that we know how to use our diaphragm when we breathe, let's put this together to take a nice, effective, deep breath. When we take a breath in, we are going to inhale through our nose. Remember to use your diaphragm and have your belly rise out. When we exhale, we are going to exhale through pursed lips, like this. Okay, let's try this together. Breathe in through your nose. Exhale through your mouth. Now, if you are sitting, I'd like you to think about placing your hands on your lap and turning your palms up. If you're standing, I'd like you to think about turning your palms out, like this. What happens here is our shoulders will rotate out. And because they have rotated out, we are actually increasing the amount of space in our lungs for the air to enter into, and it allows us to take an even deeper breath.